And now moving on to another entity, especially in the fractures and dislocations, the adults will be moving on to simple elbow dislocation. As you know, simple means that it's not associated with fractures. Briefly discussing the mechanism of injury and pathology, clinical features and how to diagnose it, and what is the treatment along with its complications. Simple elbow dislocation is one without a fracture. If it's associated with fracture, it becomes a complex elbow dislocation. Although flake avulsions of the ligamentous insertions may be seen, but that actually do not enter it into soft tissue injury, does not preclude into a complex fracture dislocation. Simple elbow dislocation is mainly classified on the basis of direction of displacement. As you know, the most of the time in the fall results in the posterior displacement of the elbow. When most common is also posterior lateral in 90% of the cases. Although usually it can be posterior medial as well, but most of the time it is, in the case 90%, it's always posterior lateral elbow dislocation. Almost in 2% of the cases, which is very less, usually results in anterior dislocation. And the mechanism was such that sometimes fall on the outstretched hand results in posterior lateral dislocation. Fall on the flexed elbow can only result in anterior dislocation, or the injury is direct, such a force that this upper part of the arm is actually fixed, and actually the injury is occurring from posterior to the anterior aspect only. All this very rarely, but it can happen as well. Coming to the anatomy, you have to understand that the elbow is actually a complex hinge joint. When you call the hinge joint, means there is only flexion and extension which occurs at it. But why it's called complex? Because actually it's formed by 3 bones, not by 2 bones. There is the distal humerus, which is actually forming a medial condyle and a lateral condyle, which what results in this is actually on the medial side it's articulating with the ulnar Olecranon. On the lateral side, this capitellum is actually articulating with the radial head. So it's a kind of a complex hinge joint. Stability is due to the shape and fit of the bones. As you can appreciate over here, the distal ulna is the trochlear groove in which the ulna accommodates, in which the humerus accommodates. And surrounding soft tissues are also important, especially the medial and the lateral collateral ligament. Ligamentous disruption results is actually a destabilizing factor, especially on the lateral side, and most commonly it is the lateral ulnar collateral ligament, which disruption can make the elbow unstable. Forearm is usually slight valgus in relation to the upper arm, which is important because that has to be especially the carrying angle, or called the Bowman angle, actually is important, especially which need to be looked out. Screw is actually on the axis of rotation, which means when we are fixing these fractures, or especially when we are fixing the elbow dislocation, we need to look at the axis of rotation as well. Now coming to the mechanism of injury and pathology. Majority of the dislocations are due to the fall on the outstretched hand, especially it's a posterior lateral injury with elbow in extension and often with the valgus force. That is why more than 90% of the injury results in either the posterior lateral displacement of the olecranon. In sports, other mechanisms may occur, especially the medial ligaments may be torn, and which could be seen on the MRI scans in all cases. Now coming to the other injuries, mechanism of injury, in 20% of the cases, the lateral ligaments either intact or have only low-grade partial tear, which more than 8% of the elbows problems of recurrent instability persist. Why? Because simple dislocation was there, closure reduction was done, but there was the soft tissue injury was not adhered to, which is important, which results in recurrent instability and may be related to associated avulsions of humeral attachment or of the secondary stabilizer of the elbow, that is medial lateral collateral ligaments. Now coming to the simple dislocation mechanism, as I told you, associated with the damage to the surrounding nerves as well, damage to the blood vessel, or especially injury is open. Usually, if the open injury is there, this is highly unlikely that it's not associated fracture, but this is although rarely it can happen as well, that open fracture dislocation can happen as rarely as well. Now, so usually if it's open, they suggest a more high injury to the trauma. Now coming to the clinical features, as it is a simple dislocation not associated with fractures, therefore the elbow of the patient will be in slight flexion, swelling would be severe, deformity would be obvious, and patient will not be able to move his arm, and that is the elbow flexion extension would be extremely limited. Pain and swelling would be marked in most cases, and examination of the elbow would be impossible. This is the method which is being used actually to reduce the elbow joint. Is you keep it at 80 degrees, apply a traction under general anesthesia, and there's a close reduction maneuver can be done in the case of simple dislocations. How do we diagnose it? The option is always the X-rays. Get an AP and lateral view, and that is why the lateral AP view comes into importance, because if we are looking for fractures only, we have to look for alignment of the bones as well, which could be disrupted in the form of subluxation or dislocation as well. And if you see this over, the anterior humeral line is not going through the capitellum. Capitellum is going away ahead, and this appears to be the trochlear groove is empty, and olecranon is displaced posteriorly, leading to a simple dislocation. X-ray examination is essential to confirm our presence of dislocation and to identify associated injuries. To assess whether it's a simple dislocation, it's a complicated dislocation. Now, once we diagnose it, it's a simple one, not associated with any fracture, but yes, there will be definitely some amount of soft tissue disruption. Then we do close reduction maneuver to reduce it back. That is, in a fully relaxed, besides the sedation or anesthesia, usually general anesthesia, reduction can usually be achieved. There's another way of it as well, that you keep the arm immobilized, applied the traction so that the posterior lateral dislocation eventually comes back to normal position. But that important point is distal nerves and circulation has to be checked. If there was associated with neurovascular injury, then we may have to operate, especially in case of arterial injury, we may have to go for repair of the vessels at times. Then the arm is held in cuff and collar. And passive stretching with elbow exercises is started around after 4 to 5 weeks. Initially, it has to be avoided for at least 4 to 5 weeks so the soft tissue can heal over time. Now coming to the definitive treatment, MRI defines the extent of soft tissue injury and why we need to look at it, because what is the status of medial lateral collateral ligamentous injury? Because soft tissue injury usually produces instability, therefore we have to assess it properly. And role of examination and anesthesia is also important so that we can see how much valgus and varus stress can be taken by the elbow at times. And if we are suspecting that there is elbow unstable, then probably we have to go for overstabilization of the elbow as well. Now coming to the complications. Complications could be at the time of injury as well, or could be associated with the close reduction. This could be in form of a vascular nerve injury. Initially, there was no neurovascular damage, but once the close reduction done, this resulted in a neurological injury as well, or vascular injury. Now, the later complications include elbow stiffness, heterotropic ossification, recurrent dislocation because of the soft tissue injury which was massive and was missed initially, and may have resulted in a recurrent elbow instability, or osteoarthritis, or unreduced dislocation. Sometimes what happens is that initially the dislocation was reduced, but it subluxes again or dislocates again, and when the check X-ray comes in, this is associated with dislocation as well. In this section, we have briefly gone through what are simple elbow dislocation. These are those in which it is not associated with fractures. 90% of the cases, it's most of the time the fall on outstretched hand leading to posterior lateral dislocation. But usually in less than 2%, anterior dislocation can occur depending upon the associated how much force was acting on the elbow and in which direction. We have to look, in case it's a simple dislocation, the diagnosis is based on X-ray, AP and lateral view. And what is important is to assess the elbow for medial and lateral collateral ligamentous injury and valgus and varus instability as well. Sometimes MRI may be needed to assess for how much damage has been done, because otherwise recurrent instability and recurrent dislocation can occur as well. Once we have made the diagnosis that it's a simple fracture, simple dislocation of the elbow, close reduction under GA can be attempted, and once the reduction is complete, we can keep the patient elbow immobilized for 3 to 4 weeks along with the analgesia and let the swelling settle down. Usually, but if associated with a massive median lateral collateral ligament injury, sometimes open reduction and stabilization of these structures has to be done, because it will later on represent the patient with the recurrent instability. Thank you very much. Keep watching sqadia.com.